I mean, so the main, and this isn't necessarily unique to community services, but it's sort of the first scenario where I'd come across it in detail is the caseload nature of the demand and the work, which is very different to, what I've come across in terms of acute providers. They're much more used to kind of one in, one out. So if you take like an example like diagnostics, where you largely the demand is, you have one request, one act, you carry out a unit of capacity to meet that demand, and that's it. Notwithstanding kind of things like surveillance and follow up and so on, but much more simple approach. Community in this case, and certainly for the Chant service, it was much more difficult because it's entirely caseload based. I mean, these patients could be staying with the service for any period of time. You go around questions like, oh, do we take an average of the number of appointments a patient has? That we kind of hit a dead end with that because it wasn't really useful to the service. It was so we started, you go around all these questions of how do you account for these differences. And I think one of the biggest differences was around the service is very, these clinicians think of themselves and think of capacity as time, as kind of clinical time on job plans and so on, which if, capacity in the NHS, which is workforce driven, does largely end up like that. But with most other areas, you can kind of quantify it in almost like a booking schedule, or you kind of have a predetermined amount of capacity. Time in job plans is more how you deliver it rather than having debate or quantify capacity around that. And this was an interesting one for the community teams, because I think that was a really difficult conversation, because there was a way, and there is a way, where you can kind of apply that same principle of, okay, you have, how many slots do you have in your clinic to book into? That's all possible, but the shift in mindset is much harder, I think, because that is just how these community services run, and I don't think they do necessarily hold themselves rigidly to these kind of clinic structures, because they have such deep relationships with their patients that they will do what needs to be done, and they're quite elastic in the way they approach capacity. So accounting for that and the level of variation and flexibility in capacity was quite challenging as well, because again, you've got to come back to the principle of there's what you're doing to keep pace, and then there's what you're kind of funded to actually deliver, and usually there's quite a big difference between the two. Services always go above and beyond, clinicians always go above. But when, ultimately we're trying to work through and define a gap that will end up in a business case, and your baseline for that is effectively what's in contract, what are you funded to do at the moment. So you kind of have to move back to that original position and structure things around that. And that again is very much around the conversation you're having with the clinical teams, and trying to build trust in your approach, that they understand that approach, that you're not kind of purposefully underestimating capacity. Actually, what we're trying to articulate here is just how far the service is willing to go in order to meet the current levels of demand, which are, at the point that you usually end up modeling far in excess of what the service is able to cope with. So kind of in summary, it's kind of the nature of the work is very different. The caseload nature of it is a challenge, and I think it's difficult for people just to wrap their heads around, because it's slightly intangible, a bit abstract. And also, the conversations you have with the clinical teams are, in my experience, very different than what I've had in acute providers and other services that are probably slightly easier to model, so a bit more simple. Well, we just had a conversation to begin with. I always think it's best not to overwhelm people, because demand and capacity can be overwhelming at the best of times. And I'm not an expert by any stretch of the imagination, but I have a bit of experience in it, and it's useful just to kind of, they're coming at it with a huge amount of expertise in their area. I try and approach it with a bit of kind of expertise and experience in modelling, and then what you're trying to do is meet in the middle somewhere. You're trying to meet some sort of mutual understanding where you both get enough out of that conversation to agree and understand what the right approach would be. So there's always a degree of kind of translation or mediation required. So we started with just a kind of first conversation where we just talked through what the problem was, where they felt the problem was, how the service runs, how it manages itself, and then there's usually a pretty good framework you can center that around, because it's usually demand and capacity. So we were talking about, how you receive demand, how do you monitor it, where do you go to if you need to figure out your caseload size. That kind of conversation led us very quickly as to who we might approach to get data to support demand, and that conversation kind of led us down it was a very easy road at the end of it, because they were quite the informatics team that supported them were really helpful. And then on the capacity side of things, that was, as I've mentioned, it's a little bit more tricky to try and translate that into something that can be modeled, because the conversation will inevitably start about kind of clinical time, and it will start about job planning. You'll talk about all the variables and the kind of dependencies that go into whether capacity can be delivered or not, which in itself can be completely overwhelming. You start thinking, how on earth are we going to model all of this? But then it's, as with any other kind of D&C approach, you have to come back to the principles. You have to come back to the main framework, which is, break it down into kind of what's your unit of demand, and therefore how does that work in terms of capacity, therefore what's your unit of capacity, and then how does that balance with what the service is telling you in terms of kind of job planning and so on. So that conversation took a bit longer, but it was much easier to kind of do once we started it. I think it was more of a conceptual challenge than it was actually a modeling one. So yeah, the first conversation is very much just kind of open-ended, and then we started digging into data, and then once we get hold of data, you can kind of start putting that into kind of an SPC chart, and then we talk again to the service and say, how does this look? Does this feel about right? It's saying your caseload your average caseload is about this much, and generally they will always have a feel for what's right and what's not. And you can look at things like, number of appointments that roughly happen, the length of the appointment, and so on, and all these variables they will know off the top of their head. So you start building trust in the data you're collecting and the approach you're taking. And the same with capacity. It's the same thing. We basically take the conversation we've had, put that into the model, walk that through with them so they understand how it's working, and that again builds trust. So we just continued on that road where we would catch up again, talk through what's happened, explain the approach being taken. They would understand that. We'd agree actions, go away, do them, come back again, and we did that for about a month or two. You were meeting at points weekly, probably on average every 2 weeks, and so that's how we kind of approach the modeling, which was, we've done that before in other areas. I think it's a very successful way of approaching things, because you just inherently need that trust in modeling when you're doing it, because if you just go away, do the modeling, come back and present the findings, they're not going to know what's gone into it. They're not going to know any assumptions you've made. So it's really important, in my opinion, that the service and the kind of specialists are brought along that journey with you, and that they're almost part of that modeling exercise, which does slow things down slightly. But I think it's too valuable to miss, in my opinion. Well, we started with the core model because it's always my default, and then very quickly figured out that wasn't going to work, because of the way the service is structured and the way that most community services are structured, is that you receive a referral and you manage that patient for a period of time. Sometimes that period of time is easy to determine, other times it's not. And there were lots of different specialties, each managing their own caseload. And in this particular case, they all shared capacity because they all turned up to the same clinic rotas and were delivering capacity in the same physical space. So the core model couldn't deliver that for us, because that it can't account for that kind of how are you managing that caseload week to week, and the level of complexity that's required in terms of managing capacity at that caseload level, but in the wider context of an MDT approach. So, I mean, we knew about the caseload model because it'd been spoken about in a number of kind of D&C meetings that we've been part of. So we were really excited to kind of give it a go. We found, it's very different to the core model. So it is a bit, it's harder to wrap your head around initially, but actually once you're comfortable looking at it, you start to see that the principles are all there. And the approach is, that kind of wider framework is all there. It just looks a bit different, and there's a few extra things to account for the complexity I've mentioned. And actually, after sort of a few attempts at breaking it, it was perfect. It worked really well. And actually talking it through with the service, when we were going through each kind of tab in the model, they could see how the purpose of each tab fed into some element of complexity or some variable that they'd mentioned was really difficult to try and model, and they could see how it was being taken account of. So, for example, length of appointments and how that might differ between specialties, news and follow-ups, and how like the length of a physio appointment might be different to a dietetic appointment, and so on. And there's the service tab is really easy to kind of structure in that way. And also kind of accounting for the different number of interventions you do, or the different appointment, the number of appointments that you would have within each specialty, and potentially within each treatment type as well. So that's all there and built in. It's all possible to take account of, which is incredibly useful. And the second bit that's really, really useful about it is the capacity side of it, the ability to account. So we could account for where it was happening, so North or South London, Southeast London, the specialty, how many patients were being seen in that specialty, by that specialty in that clinic. So there's an enormous amount of detail you can get into around the capacity. It's not always, it's not a case of simply just entering those points. You kind of have to account for it as you would, as you have to in the core model as well. But it's all doable within that capacity model, which was, really, really useful. And again, there was all the, some of the bits that we didn't quite get into this, but we plan to, is the kind of critical resources element as well, which we know is built into other models. But that was really important for the community services, because, and especially for CHAMP, because it's a really useful way of accounting for skill mix, where like a band 7 would, could deliver X amount of capacity or only a certain type of demand, and equally a band 6 might do, you might do things differently and commonly do. And that's really important for community services, I think, because that's much more of a not an issue, it's much more of a thing. So it's more important to account for that than we probably would have done in other models. So that, I think that's why the caseload model really lended itself to being a really applicable model to use in this circumstance, and absolutely would use it again for kind of any other specialty that works in a caseload way, and we'll probably advocate for that over use of the core model, where you probably need to take a bit of a more simple approach just to make it work accurately within the model. It's all doable, but I think the caseload model is just it's built for it, so it just works. It just works in a much easier way. If they are used to using the core model, or kind of any other models that are similar to that, I would say just take your time with it. I mean, because I was overwhelmed when I looked at it first. I thought, I do not understand this, and part of that is because I probably didn't understand caseloads as well as I could have done before kind of approaching this problem. So we had a support surgery where we walked through kind of the problem with the national team, and they were incredibly helpful, and they kind of broke down the caseload model into a way that I recognized. And it didn't take much. But once it was done, it was very easy for me to go, oh, well, that makes sense, and this is how the model is working, and actually if I tweak this, then it'll account for that thing that I'm trying to make work. So yeah, main advice is take your time. I would say definitely utilize support surgeries if you can, because they are incredibly useful, even just to kind of have confidence about the approach you're taking, and get any answers to questions you might be asking. I would say definitely spend and invest the time getting the service that you're modeling used to the caseload model, how it looks, how it works. They don't have to be experts, but it will definitely help kind of build trust around the modeling approach and the model itself, which, as I say, is incredibly important. And ultimately, in an ideal world, they'd be going off and using it themselves and tweaking it themselves with any kind of refresh or any different questions they want to ask. So definitely bring them along with you as well. I've mentioned a few already. The data was a bit of a challenge initially, because the informatics team we ended up working with had essentially never been asked this question before. They'd never been asked to kind of extract a weekly caseload for each of these specialties. They had a report which could tell you the current caseload, but trying to articulate kind of at least 52 weeks of a caseload run was challenging. And we had a few goes at that, and we didn't, we had to kind of tweak it each time because it wasn't quite what we needed. And also we found that there were kind of additional elements that we needed to add in, and that could, it's part of that is that none of us had done it before, so we didn't know necessarily what the right things to ask were, and so you inevitably have to kind of come back and ask for a bit more. And then I'd also say, from the capacity side of things, that was the challenge there, was, and I've mentioned this, is around trying to get the service to understand the modeling approach that you're using, because you inherently have to simplify to some extent. You have to provide some structure around that capacity, and again, bringing it back to you're trying to model what the service is provisioned to provide, not necessarily what the service is providing in excess of that baseline. There are a few challenging conversations, because you're effectively in conflict there around your approaches. I'm making it sound much more tense than it actually was. I mean, my experience of community services is they're just incredibly friendly and want to make things work, and they're totally open to kind of new approaches. So it's a relatively straightforward conversation, but it is a challenge that you can't really get around. Whereas my experience with other kind of more acute based modeling approaches is that it's much more simple, because that's kind of how they think of things anyway, one in, one out, which makes it sound very very clinical. But yeah, I think it's that type of conversation with the service is a bit more challenging or harder, which is enjoyable because I took learning from it as well. So it's a challenge that's worth doing. Yeah, definitely. So I'm in talks at the moment with mental health teams around children and young people's mental health services, and a few providers which are looking at, they're just starting to approach this demand and capacity question, and that's very much, very early stages. Not people aren't quite clear what it is they want, and therefore it's making the whole question around what model do you use and what approach do you take a bit difficult. But my simple view of those services, as I understand them at the moment, is they would completely lend themselves to using a caseload model. I have this ambition of trying to get them trying to get it to work for things like chemotherapy day units, where they work a little bit like caseloads. You have patients coming back at regular frequencies, predetermined frequencies to most of the extent, and it should be, in theory, possible to monitor that, because our historic approach has been to just take the total historic attendances, or the requests for an attendance, and look at that over time, rather than being able to necessarily say that, right, the caseload is broken up by this amount now. All of those treatment types take different amounts of time, and therefore this is what it's likely to do over the short term, or that's the capacity required in the short term. I think that would be an incredibly useful view. Haven't approached that problem yet, but I think, you know, though anything that works in a caseload manner, which is obvious to say, completely lends itself to using this type of modeling approach, because I think anything else, you have to simplify the service to the point where it no longer represents how the service is actually delivered, which means that the demand and capacity output is just harder to understand and therefore less likely to be used and less likely to be useful. So yeah, anything that has that caseload approach lends itself to using the caseload model, and I would say is a much more valuable model to use than what I've previously attempted to use for those sort of questions.